Ladies and gentlemen, welcome to the Early Recognition and Management of Sepsis, a post-acute setting toolkit. Your host for today, Kathleen Lavich. You may now begin.
Hello everyone, this is Kathleen Lavich with Untitled, Michigan's Quality Improvement Organization that is part of the Lake Superior Quality Innovation Network, or Lake Superior CIN. Lake Superior CIN represents Michigan, Minnesota, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is being presented in a collaborative effort between the Lake Superior CIN and Great Plains CIN, which includes the states of Kansas, Nebraska, North Dakota, and South Dakota. One concept often nurses will be provided for today's webinar by the North Dakota Board of Nursing. When you close out of this webinar, you will be automatically redirected to the evaluation. In case you have multiple attendees, the evaluation will be emailed to the individual from your facility who logged into the webinar. This email can then be forwarded to other staff members and attendants who wish to receive the continuing education certificate. The certificates will be sent 3 to 5 business days after completion of the evaluation. Since sepsis is a top readmission diagnosis for patients in all of our states, we are focusing the webinar series on sepsis. This is webinar part 2 of the series. I would like to welcome you to this educational session entitled Early Recognition and Management of Sepsis, a Post-Acute Care Settings Toolkit. Before I introduce our speaker, I'll mention that all lines are muted during this webinar. While after the presentation, we will have time for questions and answers, so please make a note of any questions that may come in after the answer. Or you can use the chat feature, which is on the right side of your screen. Now I'd like to introduce our speaker, Pat Koza. Pat Koza is a population health clinical innovation leader for St. Joseph's Nursing Health System in southeastern Michigan. Pat has been involved in many quality and patient safety programs, such as hospital and wide centralized sepsis management program, and a statewide Keystone ICU patient safety initiative. She has been faculty for multiple state and national clinical programs, including the Surviving Sepsis Campaign, Phase 4, Collaborative, and the National Project on Comprehensive Unit Safety Program, or CUS, for mechanical ventilated patients. Through Pat's leadership, St. Joseph Nursing Hospital is awarded the Department of Health and Human Services and Critical Care Society's outstanding leadership in eliminating CLABSI and ventilator-associated pneumonia in 2011. She was inducted as a fellow into the American Academy of Nursing in 2013. In 2017, Pat was awarded the Michigan Hospital Association Quality and Patient Safety Leadership Award. Pat, I will turn it over to you.
Thank you so much, Kathleen, and I'm excited to be here today talking with all of you. I did the first presentation in this series and focused on what is sepsis and how to manage it, the science behind it. And today we're going to talk about, and we focused a lot on in hospital care. Today we're going to focus on what can you do in the post-acute setting. And we have put together a toolkit to assist hospital organizations in working with skilled nursing facilities to care for their patients and help them early recognize sepsis and prevent infection. So what we're going to talk about today and the program that this toolkit will support, we'll talk about the program objectives, what each of the facilities' expectations are, as we have multiple meetings with the facilities to help them put the sepsis program in place in their organization, what those meetings look like. Talking about the expectations that we set for the facilities, how to prepare for each meeting, and give you a broad review of the different components of the toolkit, and then allow time for questioning. So the premise behind this toolkit is, as we have identified, and I'm sure that it's common, I know it's common across the country and also in the state of Michigan, that sepsis is the #1 cause for readmission. And we had identified that as we continue to standardize and perform early identification and management of sepsis in our hospitalized patients, as we continue to look at patients that came to us already in septic shock, where they're already far down the road in the sepsis pathophysiology, is there a way to have caught these patients sooner? And so we looked at where the patients were coming from, and a large number of them were coming from skilled nursing facilities. At that same time, we were beginning partnerships and had partnerships with skilled nursing facilities. So the hospital that I work at is St. Joseph Mercy Health System in southeastern Michigan. It's in Ann Arbor, Michigan. And so we brought together a number of skilled nursing facilities that we commonly send our patients to, and began working with them collaboratively to improve communication, and then to try and standardize care processes that we have in the hospital, standardizing them as well to the skilled nursing facility. As a result of that, we created a sepsis collaborative where we held monthly meetings or bi-monthly meetings where we assisted the facilities in doing the work of standardizing early recognition and management of sepsis. So we put that into a toolkit. And so the toolkit starts off with an overview of how you can use this toolkit, and then to make it easy for other health systems to replicate what we've done, we have included all of the training materials, action plans, agendas, presentation slides for each of the meetings, educational videos, and then sepsis tools for early recognition and management, and then links to other resources. So what I'd like to do is share with you the different components of the toolkit. I gave you some background on what our goal was and how this came to be. And so as we met with, so we identified a number of facilities that we were sending our patients to, our highest volume facilities, and invited them and anyone else who wanted to be involved to work with us to standardize early recognition, prevention, and management of sepsis. And so the program objectives were to have the skilled nursing facilities, so the subacute areas in those facilities, develop and implement an early recognition of sepsis process, and then also standardize processes for treatment of patients with sepsis. And then because we know infection leads to sepsis, if we can focus on infection prevention, we can decrease the number of patients that might get septic as well. So we worked with the facilities to help them standardize processes for infection prevention related to pneumonia, clotting and UTI, and CLABSI. With our overall goal being to decrease the rate of transfer to higher level facilities. So it's never good for a patient to have to transfer them back to the ER or to the hospital when if there was a way to prevent it. It's disruptive to the patient, it's disruptive to the family, it's disruptive to the facility. And so we want to be able to minimize those, but understand that there are always going to be some times when patients will need to go back to a higher level of care. But overall, we hope to decrease that rate of transfer and then decrease sepsis mortality rate. So we did monthly 1-hour face-to-face meetings. We began in 2016, and in 2016 we did it every other month and had 6 meetings. In 2017 we did it every month for a 6-month period. And now this year we're doing it throughout southeastern Michigan. And we're doing it monthly over a 5-month period, and we're running 2 courses, one March through July, and then repeating it again in August through December. And the goal of the program, which is outlined in the toolkit, is to walk through an action plan to implement a sepsis early recognition and management program that also includes a focus on infection prevention. We also included in the program is 2 site-specific coaching calls over the first 3 months to provide individualized support. And so, and these would occur in between the meetings. Our goal is to provide training and educational materials to the facilities so that they don't have to reinvent the wheel, because we know that they're often resource limited. And then we define some process and outcome measures to evaluate the success of the program. So we set expectations for the facility. To be a part of this program, each facility needed to have identified a team that would do this work, and they could send representatives of that team to the monthly meeting. And that team at the facility should include at a minimum the medical director, the director of nursing, an infection prevention, and an infection prevention nurse. Typically attending the meetings is the director of nursing or their designee and an infection prevention nurse. That team should be walking through the action plan within a specific time frame, so we set target dates for different tasks. We would expect them to implement a sepsis screening process in their facility, as well as to implement an early management of sepsis process. Along with this, they would need to educate their staff on sepsis screening and management, and that would be initially prior to starting, and then putting in place an ongoing educational process as new staff get onboarded into their facility. We also expect them to assess their current infection prevention practices related to pneumonia, UTI, clotting, and CLABSI, and identify an intervention to improve upon. And then they need to collect process data, and we're working with them to use outcomes data. One of the first things we did was send the facilities a readiness assessment, but prior to that readiness assessment, we had sent out what was called a call to participate, which outlines the program goals and objectives and the facility expectations, and it required the signature of the administrator of the facility, because we wanted to ensure that the administrator was supporting it. Then, once we received that signed call to participate form, we would send them a facility readiness assessment. And this would ask them a series of questions just so that we would know where their needs were, and they would also know the key components that would be required to help this be successful. So, asking if they are doing any sepsis screening currently, whether they feel their staff level of sepsis understanding is, are they interested in learning more, and then do they have the key components and resources in their facility to support this process. So, first meeting, the goal for the first meeting was to introduce facilities to the program objectives and the expectations for them, do an assessment of their current knowledge on sepsis, review a sepsis action plan. At each meeting, we defined some homework or next steps that they needed to do between the meetings, so prior to the next meeting. And then we reviewed at that first meeting the purpose and expectations related to coaching calls. So you can see here that here's an example of what the agenda looks like, and these are available in the toolkit. Again, our goal here with the toolkit is to be able to give facilities, the hospitals and skilled nursing facilities, the tools necessary to put in this program successfully without having to reinvent a lot of things. So the key takeaways we wanted the attendees to walk away with were that they understood the program and the expectations, that they now had a basic knowledge of what sepsis was, its management, and how to screen for it, and that they understood the homework and coaching call expectations. So you can see the first session is an hour and a half, and the other sessions are only an hour, and each time in the agenda we have area of focus. So we'll provide content to the attendees. And in the first one, it was what is sepsis, how to manage it, and how to screen for it. So one of the benefits of having the people come face to face, so we have multiple facilities, I would recommend 10 to 15 at a meeting, because at each meeting we're having them interact by sharing success stories or sharing the homework that they did and the results of it and where they might have issues and barriers, and to be able to effectively get through 10 different teams sharing what they've done. It takes a little while, so you want to have between 10 and 15 facilities there and not many more than that, or it would become a challenge. So we have them introduce themselves, their role, and what work that they've done so far on sepsis. And the byproduct of these meetings is that the facilities get to learn from each other. They brainstorm together about problem solving different issues. They also get to hear that some of the issues that they're having might be very common, and other facilities are experiencing it. So it's time to network and work with each other, which is very important. And that's why this program was not done as a webinar series. It was a face-to-face, and that made it more successful. So at the beginning of the class, we wanted to have them ask what their knowledge of sepsis was, and so we gave them a 10-question pre-assessment, and they could use this form and this pre-test at their facilities with their staff. So everything that we're providing them, we encourage them to use it with their staff, so they can use this tool to assess their staff knowledge pre- and post-education. Then we introduced, after educating them on sepsis and how to manage sepsis, we talked about how to early recognize sepsis through screening. We provide them with this screening tool. A lot of facilities that we've worked with have now put this into their EMR, so it goes better into their workflow. But as you know, in sepsis, we're looking for a known or suspected infection, someone that has 2 or more SIRS criteria, systemic inflammatory response syndrome. And so we actually put that first, the systemic inflammatory response syndrome, so as we walk them through the screening process, and I'm going to go into detail on that screening process because this is the key component of the sepsis program is that early recognition. So we're asking the facilities to screen upon admission every shift times at least 7 days, and then with a condition change, or if there's a stop and watch alert from the SUNA that they report to the nurse should screen for sepsis. If someone is on antibiotics, they should be screened each shift while they're on antibiotics. And that's the minimum. The majority of the facilities that we were working with, as they implemented the screening, they saw the benefit and are screening their subacute patients every shift, every day for their entire stay. So that screening does occur upon admission, and like I said, every shift with condition change or with the stop and watch alert. The first question, the first part of the screen is to answer the question, does this patient have signs of systemic inflammatory response syndrome? So looking for the temperature, heart rate, respiratory rate, white blood cell count, and don't use it if it's greater than 24 hours old. If I have temperature that's greater than 101 or less than 96.8, or a heart rate greater than 90, or the respiratory rate greater than 20, then check your blood glucose in a non-diabetic to see if it's greater than 140. If I have not checked 2 of the above, then I'm done with the screen. If I have checked 2 of the SIRS, then I move on to the second step of the tool, and it's answering the question, does the patient have a known or suspected infection? So the screening process is really having your staff answer 3 questions. Does this patient have signs and symptoms of the systemic inflammatory response syndrome? If they have 2 of those, then we move on to asking the question, do they have a known or suspected infection? If I answer yes to the 2 or more SIRS and to the known or suspected infection, then I move on to looking for, does this patient have new organ dysfunction? So if the patient has 2 or more SIRS and has a known or suspected infection, now my patient proves positive for sepsis. And the recommendation is that you increase the frequency of monitoring vital signs on that patient because you want to watch to make sure that they don't progress to severe sepsis or septic shock. And you should collect INOs on those patients and obtain a lactate so that you can monitor for organ dysfunction. So the third step or the third question is, does this patient have any organ dysfunction in an organ system distant from the site of the infection? And so here we're the major organ systems that are easy for skilled nursing facilities to evaluate are the respiratory system. Does this patient have a stat that is dropping less than 90%, or have they had increased O2 requirements? Cardiovascular, we're looking for a systolic blood pressure less than 90, or a 40 millimeter of mercury drop from baseline. Renal-wise, and this is why urine output is so important, is urine output less than 25 milliliters per kilogram over the last 8 hours. Milliliters per kilogram per hour over the last 8 hours. And mental status changes in looking for the central nervous system. Labs are important in the hospital, in the post-acute setting. If they have these labs available and they're in the less than 24 hours, they can look at platelets, INR, bilirubin, and obtain a serum lactate. Again, you don't want to use older labs. If I have any of these organ systems dysfunctioning, now I have severe sepsis. And if I have severe sepsis, then we need to make a call to the physician or the provider and follow the S bar that's at the bottom of the tool. So the situation is the resident has screened positive for severe sepsis. We describe their stirs, the known or suspected infection, share which organ system has dysfunction, and provide any other assessment data or vital information that you want to share. And the recommendation is you want to request blood cultures, the CBC, lactic acid, IV antibiotics, and if the patient's systolic blood pressure is less than 90 or 40 millimeter of mercury drop from the baseline, you need to get an order to administer the fluid bolus of 30 milliliters per kilogram over an hour. And if after that fluid bolus the resident's hypertension is not resolved, can I send them to the ER? Because then they've moved into septic shock and they need to be treated in the ER. So it's important, and this is just a summary of that severe sepsis bundle. So this is the recommended, based on the best evidence, interventions that should be done when a patient has severe sepsis. And you can see it's the blood cultures, the lactate, the broad spectrum antibiotics, increased monitoring of vital signs and intake and output, and then treating the patient if they're hypertensive with a fluid bolus. We wanted to make sure that this was linked to other processes in the post-acute setting, and a majority of the facilities do use the Interact tool and the stop and watch component, where the CNAs are instructed that if they see any of these signs on the patient, and it's in the acronym of stop and watch, that they should notify the nurse. And so, as I stated before, you would want to put into your screening process that if the nurse receives the stop and watch notification, that they would perform a sepsis screen. Here's the example of the action plan that guides the program, and you can see it's a pretty simple action plan. It doesn't mean it's simple to do, but it's just like any other change in practice or performance improvement. You need to get a team together to create that early recognition process, ensure that you get medical staff support for screening and early intervention, develop that screening tool process, defining the frequency, and again, we're providing them with the screening tool, and they need to work into how do they put this into their processes in their facility. We gave a recommended frequency at a minimum, but they can do more frequency if they wanted. And then the fourth step is to define the content for staff education, who's going to provide it, and then plan and implement that staff education. We also, so that's usually, once before is the homework after the first meeting. Other things we'll focus on are patient and family education tools, evaluating a screening audit process, and then developing an infection prevention educational plan for pneumonia, UTI, and CLABSI. So each of the meetings has associated presentation slides, and in those presentation slides, we review the program goals, objectives, and expectations to ensure everyone's on the same page. And then the second component is a round robin, except at the first meeting, the round robin is introduction for everyone. At the following meeting, subsequent meetings, the facilities share the homework that was assigned at the prior meeting, and they discuss issues and barriers so that the group can brainstorm together. Then we present the new content for that meeting. We review the homework that is being assigned at that meeting, and then we have them sign up for coaching calls. So the round robin is probably one of the best pieces of the program in that you really get facilities to network and share with each other. Lots of good learning takes place. And it also is a way to establish some accountability that we expect that if you're going to be a part of this program, that you're all in and you're going to do the work. This is not just come and listen and go home and do nothing different. We expect that you're doing something after each meeting so that by meeting 3, you will have implemented the screening process. You will have educated your staff and implemented the screening process. So the round robin occurs at the beginnings of the meetings, and the facilities will share the results of their homework, discuss issues and barriers. It allows networking between the facilities and holding the facilities accountable. So the second meeting is focused on ensuring that the part of the homework for the first meeting was they were taking that screening tool and they had to go to the facility and screen 10 patients and then come back and discuss how it went. What questions did they have, and give feedback on, okay, so you did it, so how are you now going to incorporate this into your work processes at your facility? So that round robin, we had them, besides sharing the results of the screening of 10 patients, they had to complete action plan steps 1 through 4. And so we asked them how the meeting went with the medical director to make sure that they were on board with the screening process and the intervention, and that medical director would then be responsible for ensuring any other provider that shares physicians at that facility is aware and educated on this. The content for this meeting is reviewing patient educational material and then defining the sepsis screening audit process. And then the homework was set to complete items 4 through 6 on the action plan. So ensure that you have developed and implemented education, and we provide them slides for they can use for education, and we also have videos that are voiceover slides, 2 educational programs for the nurses, each 20 minutes long. One talks about why should you worry about sepsis and what is sepsis, and then the second 20-minute educational video talks about screening for sepsis and how to manage sepsis. And then we have a separate educational video for the seniors that talks about why sepsis, what it is, and their role in early recognition. So we show them some tools for patient education, and those are resources that are available in the toolkit. The Sepsis Alliance and the CDC have a lot of patient educational material. So we review that, and then we ask them as part of the homework to talk about how we should implement these educational materials. And then we have them sign up for coaching calls. So the audit process, once you put in a new practice or a new process, you want to make sure it's being done and it's being done correctly. And so we review with them an audit tool, so we provide them an audit tool, and that audit tool evaluates if screening is being done on the patient and at the frequency that's expected for each of the patients. And then we also want to know, is the sepsis screening being done correctly? So those are the 2 main components. And then we expect them if they, and this is a best practice at facilities anyways, and a lot of them were already doing this, if a patient gets sent to the hospital for an infection or sepsis, we want them to, when they review that case, to look to see if those new practices were done and done appropriately. Was the patient screened appropriately, and if they screened positive, were the appropriate treatments provided prior to going to the hospital? So here's an example of the audit tool. We have them audit weekly at the beginning, and you increase your frequency of auditing until you get to a certain level of compliance, and once they hit 90% compliance, then they can decrease that frequency to doing it once a month. So we have them pick a day, and what's your average daily census? If it's 50, then look to see on those 50 patients if your expectation is that they should be screened twice a day or each shift, then look to see if I have 2 completed screens on each of those patients from the last 24 hours, and then that would be said to be compliant. And then if I've looked at 50 patients and I've looked for 2 completed screens and say only 40 of the patients had 2 completed screens in the prior 24 hours out of 50, then that would be my compliance rate when over 50. And off the top of my head, 40 over 50, and I can't do it off the top of my head, that's an 80% compliance. And so we would want to see better compliance rate than that. But again, you're going to see a lower compliance rate initially, and it should continue to improve. Then we want you to take a 10% sample. So if I looked at 50 patients to see if they had been screened, then I'm going to take 10% of that, so that would be 5 patients, and see if they were screened correctly. So actually go into the chart, look to see if I was screening the patient at the same time that that nurse was screening the patient, did they answer the questions correctly? This is important because you want to ensure that your staff understood how to do it. And auditing allows you to identify where there's gaps or issues and then to work on de-educating or resolving what the issues are. So we expect them to submit those audits to us as part of the follow-up from the program, and that's an ongoing expectation. So the third meeting is now that they have implemented the sepsis screening, early recognition, and treatment program. The goal here is to see if they've done those audits correctly. So the homework from meeting 2 is to screen, to do an audit of your screening, evaluate how, implement that patient education, and so share how you did that. What was your plan for educating the staff on sepsis? What was your go-live date? So all of that is shared in the round robin. And then the learning part, the learning section is now focused. We move from sepsis screening and management of the patient with sepsis to infection prevention, and we start off with pneumonia. And so we share with them the best practices related to pneumonia prevention, and then we ask them to do a current state assessment where they look at their current policies and practices related to pneumonia prevention. And we also, besides looking at policies, we have them audit at least 5 patients to look to see if those pneumonia prevention practices are in place. From that, they will be able to identify where there might be gaps in application of the prevention practices and where to identify an intervention to close the gap. So here's an example of the pneumonia So the infection prevention action plan. So again, it's typical steps in a performance improvement process. You're first going to review the evidence, best practices, and determine which ones you should implement, if not all of them. Understand what your current practice is, and so that's that current state assessment. Identify where your gaps are between current practice and the evidence-based practices, identify barriers to implementing the new practice, educate your staff on the new or revised practice, and audit that new process. We're not going to define, can you hear me? We're not going to define the audit process, but we expect them if, so for example, you can see on the left-hand side here that the pneumonia prevention practices are hand hygiene, oral care, comprehensive oral care, prevention of aspiration, swallow screens, proper positioning, adequate nutrition, and mobility and lung expansion. So in both of the first two series that we did, the facilities identified that their oral care practices weren't where they thought they should be, and so they focused on that was their gap, and they identified that some of the barriers was related to their equipment, knowledge, et cetera, and they educated the staff and implemented the new practices, and then they developed their own way to audit. I'm going to talk about home health agencies in a few minutes. Someone asked in the chat box. So the fourth meeting is, again, we're focusing on infection prevention. The homework is related to the pneumonia prevention, so they need to share that. And then the learning session is focused now on best practices related to UTI and CLABSI prevention, and we send them off with the same expectations that they do a current state assessment for UTI and CLABSI. So you can see that on the left-hand side of the screen, and they identify, based on the evidence and based on their current state assessment, where there's a gap and what they need to do to improve. And then the final meeting is they're going to share in the round robin what happened with their UTI, current state assessment, given the updates on the pneumonia. We always ask, have they identified any sepsis patients through their screening process? So we started this new series, and I was on a first coaching call with one of the facilities, and they were just so excited to be on the coaching calls because as she was she was doing her homework of screening 10 patients, and she screened someone and she found them screened positive, and they intervened and started IV antibiotics and gave the patient some fluid, and the patient was doing very well. So we always want them to share any stories that they have related to the work they've been doing with the sepsis screening. And then the focus for this meeting is reviewing the CLABSI prevention, and we send them away with homework. Now, we don't have a sixth meeting, but they know the drill. They need to go and do their current state assessment and identify where their gaps are between the best practice evidence that was presented and what they found on their current state assessment. And then we wrap it up, and the expectation, because we have in our organization, we have an expectation that to partner with us and be a preferred provider, they need to have done the sepsis best practice work with early recognition and management. And so we expect them to give to us on a quarterly basis their weekly and monthly audits on sepsis screening. Just a little bit more on the coaching calls. This is, again, something that occurs between the meetings. The purpose to provide individual support to each facility to ensure understanding of the content that was presented at that meeting and the homework. The appointments are set up for a 15-minute touch base. We talk to the facility reps that attended the meeting. We review the homework and ensure understanding, and they can share success stories like someone I just shared with you did on their first coaching call. And then they discuss any barriers that they're having, and it just allows some individual time because each of the classes is building on each other. We don't want them to be behind because they didn't understand something. So that's why the coaching calls were set up. Skilled nursing facilities aren't the only post-hospital facilities that should screen for sepsis. The New York State Home Care Association, or the Home Care Association of New York State, has put in place a sepsis screening toolkit, and it's referenced at this site, and it is a good process. And it allows for screening at each visit, and based on the results of the screening, it gives what intervention should happen, and here's the sample of the screening tool. Again, it's asking the same three questions. Does the patient have an infection? Do they have 2 or more of the SIRS, and do they have organ dysfunction? And then it defines the follow-up and the interventions that need to be done. So it's a good tool. We have are ready to pilot something very similar with our home care agency. I think it's a great thing, and this work also needs to spread to primary care offices as well. So what are the outcomes? We hope to have better outcomes for our patients through partnerships with the post-acute providers. And so here's some of our results. Again, remember we just began this in 2016, and so the data I'm showing you is past data extending from, and this is Medicare data based on claims. And so this data was provided to me by MPRO. And so the baseline is quarters 3 and 4 in 2014, and it ends in quarter 3 of 2017. So quarter 1 through 3 of 2017. And so we looked at 30-day sepsis readmission, 90-day, and then 30-day and 90-day sepsis mortality. And so on the left-hand graph is the non-participating SNFs, and on the right-hand side are the participating SNFs. So you can see that the purple line is 90-day mortality, and that both of the mortalities are taking showed an increase but decrease. But if you look at the percentage mortality, it's much higher in the non-participating facilities, 50 to 60% mortality versus 40 to 45, 40 to 50. 30-day mortality increased in both groups, but again, the number is lower, so it's under 30% versus it's 40% for the non-participating. But if you look at the
30 and 90-day readmission. The rates in the non-participating facilities is going up, and in the participating facilities it's going down. And the next slide even shows that a little bit more. So here, if you look at, so how many facilities participated? 13. And so if you look at the green line on the top, those are the 90-day non-participating readmissions. And so from 16 to 17 it went up. For the participating facilities it went down, and you see that same trend in the blue line being the non-participating facilities, 30-day readmission, and for the participating facilities it went down. So we are excited with seeing some outcomes, and positive outcomes, and again, a couple of points. It does not make a trend yet, so we will continue to follow this, but the early results are very promising. So I am open for questions. I'm going to read some of the questions that have been put in the chat. Please feel free to ask your questions in the chat. Operator, I don't know if you're opening lines for questions, or do we want to take all questions through the chat?
Yes, if you would like to ask a question over the phone, please press the number 1 key on your telephone keypad. If you would like to ask a question over the phone, please press the number 1 key on your telephone keypad. We are waiting for callers to join the queue.
Okay, so let me answer the questions that are in the chat. Can you identify dialysis patients so they don't get the fluid challenge that would possibly put them into fluid overload? Well, the dialysis patients, if they have severe sepsis, so if they have 2 or more SIRS and known or suspected infection and they're hypotensive, they need that 30 milliliter per kilogram fluid bolus because they are intravascularly dry anyways, with dialysis keeping them dry between dialysis runs. But now you add on top of that the pathophysiology of sepsis, where the cytokines cause vasodilatation and cause leaky capillaries. So now I have even less intravascular volume. It's that low intravascular volume, and then also the procoagulant state that the patients are in when they have severe sepsis that causes poor perfusion to the tissues, not getting enough oxygen, that causes organ dysfunction. And so the patients with dialysis who are on dialysis do need the fluid just like everyone else. Are the antibiotics that are started part of the action plan or ordered by the medical director? So they need to be ordered by the physician when someone calls a provider with this patient screens positive for severe sepsis. We recommend to the medical director that they adopt a recommended antibiotic tool, antibiotics based on where the source of the infection is, so that there's consistency in the use of broad-spectrum antibiotics, but that antibiotic is ordered by the physician specifically. Are you using the sepsis screening tool as a routine screening for all residents or when they start having symptoms? No, it's used for all residents. You don't wait for the symptoms. You're going to identify the symptoms by routine screening. So the minimum recommendation is this routine screening is done upon admission and every shift for a minimum of 7 days, but most facilities are doing it throughout their stay in the subacute. Now, the long-term care, we haven't set an expectation in the long-term care, but most of the facilities have decided that when someone goes on antibiotics in long-term care, oral antibiotics, that they will begin to screen them at least daily So that's the recommendation. And there are some facilities that have put this into point-click care. I know the Sienna facilities in Michigan have done that. So it would help if anyone wants to share it if you are on. If not, I will try and give a resource for people to, I'll reach out to some of the facilities that I know have done it here and see if they'd be willing to share. Would it be possible to get copies of the screening and audit tools that are embedded in the slides? Yes, so all of these tools, everything that I shared with you today is part of the toolkit. And so that toolkit will be available on the MPRO website, and we'll give you that link in a minute. Yes, the toolkit is available for participants to download. Kathleen, do you have where they could find the toolkit? Can you put a link?
We will be posting it on the LS Quinn website.
Okay. So there'll be a link on the LS Quinn website. So the graphs that I showed you were not nationwide. They were just in the state of Michigan, the non-participating facilities. Where facilities in the state of Michigan versus the participating facilities were also in the state of Michigan, but they were not national numbers. But I can tell you that 30-day readmission rates are fairly high nationally, so not inconsistent. Yes, the toolkit, does the toolkit include the educational videos you referenced? Yes, it does. This toolkit is only 3 pages long, but it has a series of links so that you can link to those videos. You can link to download the screening tool. You can link to download the Excel spreadsheet for the audit process. And so we just posted that the toolkit will be available on the LS Quinn website. Will the link also be sent to the GP Quinn to place on our website?
That's fine, we can do that.
Okay, we can do that. Any questions on the phone? I know you guys have been using the chat very well.
We do have one question come in from...
Okay, go ahead.
Please go ahead.
My question was already answered. Thank you so much.
You're welcome. So I see a question did come in on the chat. I've noticed discrepancy on what SIRS criteria mainly is blood glucose included or not. So blood glucose was, from the Surviving Sepsis campaign, was added to the early recognition criteria in 2008, and it was blood glucose greater than 140 in a non-diabetic. So you will see in most literature that the SIRS criteria, which was defined back in 1992, is heart rate, respiratory rate, white blood cell count, and temperature. But the blood glucose was added as an early recognition because we know that when sepsis happens, that our stress response is ignited, and as a result, we can see hyperglycemia even in the non-diabetic patient. So we are at the top of the hour, and I want to thank you guys for your time today and hope this will be helpful in being able to save lives for our patients and prevent the inconvenience of having to go to the hospital, but mainly so that they're going to have a successful outcome.
Thank you so much, Pat. This concludes this educational session. Before you close out today, please complete the survey that will pop up. We appreciate your feedback on today's session. Once you have completed that evaluation, you will receive a certificate of completion. Please make sure that everyone on your team that has participated in this webinar receives a copy of the certificate as well. This session was recorded and will be available on the Lake Superior Quinn and Great Plains Quinn websites in about 2 weeks. Thank you all for participating and have a wonderful afternoon. Bye-bye.
Bye-bye.
Ladies and gentlemen, you may disconnect your line at this time.